Renal function is evaluated through several important laboratory concepts. First, all non-protein nitrogen compounds such as urea, creatinine, uric acid, and ammonia are elevated in plasma during renal impairment. This condition is referred to as azotemia. The best laboratory evaluation when renal impairment is suspected is the Glomerular Filtration Rate, or GFR. Creatinine clearance is used to evaluate GFR and is more sensitive than blood urea nitrogen or creatinine alone. Estimated GFR, often abbreviated as eGFR, is even more sensitive than creatinine clearance. It is calculated using equations such as MDRD and CKD-EPI, which incorporate serum creatinine, age, gender, and race. Unlike creatinine clearance, eGFR does not require a 24-hour urine collection. The American Kidney Foundation recommends eGFR as the preferred method to assess kidney damage. When reporting eGFR, values above 60 are reported as greater than 60 milliliters per minute. eGFR values also allow classification into 6 categories of kidney function, with kidney failure defined as 15 milliliters per minute or less. Finally, urine albumin measurement is used alongside eGFR to stage and monitor chronic kidney disease. Together, these tools provide a comprehensive assessment of renal function. Let's review several key laboratory markers of renal function. We begin with creatinine. Creatinine comes from the breakdown of creatine in muscle. It is often measured to evaluate renal function, although it is not as sensitive as glomerular filtration rate. The classic method is the Jaffe reaction, in which creatinine reacts with picric acid in an alkaline solution to form a red-orange complex that absorbs light between 490 and 540 nanometers. However, glucose, acetoacetate, and ascorbic acid can interfere with this test. Next, we have blood urea nitrogen, or BUN. BUN increases in cases of impaired renal function and in patients consuming a high-protein diet. It tends to rise more quickly than creatinine. Laboratory methods include a colorimetric approach, where urea reacts with diacetyl monoxime, and an enzymatic method, where urease hydrolyzes urea to ammonia. Importantly, sodium fluoride should not be used as an anticoagulant because it inhibits enzyme activity. Normally, the BUN to creatinine ratio falls between 10:1 and 20:1. Moving on to Cystatin C. This is a serum marker of glomerular filtration rate. It is a small protein produced consistently by most nucleated cells. Unlike creatinine, Cystatin C is not affected by inflammation, gender, age, eating habits, or nutritional status. It is measured by immunoassay. Next is urine albumin. This test can be reported in 2 ways. For a 24-hour urine collection, results are expressed as milligrams of albumin per 24 hours. For a random urine sample, results are reported as milligrams of albumin per gram of creatinine. Now let's consider uric acid. This compound is the end product of purine metabolism. Levels increase in gout, renal failure, leukemia, and during chemotherapy. The traditional colorimetric method is based on uric acid-reducing phosphotungstic acid to form tungsten blue, though the test can be affected by lipids and several drugs. Enzymatic assays are also available, using uricase to produce allantoin and hydrogen peroxide, which is then measured in a coupled reaction. Finally, we discuss ammonia. Ammonia is derived from bacterial action on the contents of the colon and is normally metabolized by the liver. Elevated plasma ammonia is toxic to the central nervous system. Hyperammonemia is most often caused by advanced liver disease, including Ray's syndrome, cirrhosis, and viral hepatitis, but it can also result from impaired renal function. False elevations may occur if the blood sample is not placed on ice, not centrifuged, or not analyzed immediately. Poor venipuncture technique and incomplete filling of the collection tube can also falsely raise ammonia levels.